This is Selma Schimmel in Chicago at the AACR annual meeting, the American Association for Cancer Research, bringing you an Advocacy in Action special with our advocate in action, Ginny Mason, Executive Director of the Inflammatory Breast Cancer Research Foundation. It's great to see you again, Ginny.
Thank you, Selma.
Explain to us, what is inflammatory breast cancer? Why is it different than some of the other breast cancers?
Typically, there's not a palpable lump associated, although often people, as in my case, had invasive ductal carcinoma as well as inflammatory. I had a third kind as too. I'm always an overachiever. I have to do more than one. But it presents much differently. Typically, it is not found on a mammogram. Might be seen in ultrasound, but we tend to be younger women in our 30s, 40s, and 50s. So you're dealing with dense breast tissue, which isn't good for a mammogram as well, and looks often like an infection. There's redness, swelling, maybe itching, pain.
Is that what leads a woman to the doctor usually?
Exactly. And these symptoms come on quickly, and that's what's so troublesome to the patient. There are women who tell me they go to bed one night with no symptoms, wake up in the night and think, did I bump into something today, or what did I do? And they get up and they see this red, swollen, painful breast.
How long does it usually take for the cancer to have been there before the symptoms present?
No one knows for sure, but when you talk about standard breast cancers have maybe as long as a 10-year time from the time they begin to develop until they can be felt by a palpation or maybe even picked up by mammogram, is a much longer period. With inflammatory, the guess is that it's a very short time, probably weeks, that this has the fastest, what they say, doubling time of any kind of cancer.
And how's it diagnosed?
There is no, and this is one of the frustrations, there is no molecular test right now or blood test or anything that would say this is inflammatory breast cancer. It is still a clinical disease. So
Imaging is ineffective?
You might see on a mammogram there might be increased density.
What about MRI?
Sometimes it will show there. The definitive diagnosis comes from a biopsy of the skin. So something like it's about the size of your little finger punches, what's called a skin punch biopsy. And usually a couple of those are done in areas where you see change in the tissue, the redness or the swelling.
So the biopsy isn't like a core biopsy, it's
typically
a surface
not,
biopsy.
right, because this inflammatory breast cancer grows in the lymphatic layer of the skin. Hence the way the tissue responds when the lymphatic channels are blocked. You get the swelling, you get the redness, and all those things that look like an infection because the tumor cells cluster. My pin shows a cartoon of a tumor cell cluster, and these get in there and block that flow of fluid. And so it can be challenging to get an adequate diagnosis because it's not a common cancer, fortunately.
And it sounds like a painful cancer.
It is, and often that's the first thing you're told is, oh, if it hurts, it can't be cancer.
Correct.
We often tell people that when they're trying to get a diagnosis, when they're struggling, to contact a breast center and talk to a breast health nurse there and say, who in your institution has expertise in dealing with inflammatory breast cancer? If they're at the point of diagnosis, we say, in ruling out the disease.
Right.
If they've gotten a diagnosis, who should they see in that institution for treatment? Because often the nurses have a better handle on that than if you call an office and just talk to a scheduling person who may not have that information.
Treatment for inflammatory breast cancer, talk about that.
Typically, you have chemotherapy first because this is considered a systemic disease at diagnosis since it's already in the lymphatic system. It's already out of 4 stages of breast cancer. It's either at a 3B, C, or may already be metastatic at diagnosis of stage 4. And so chemotherapy is given to reduce that tumor burden before any other kind of treatment is considered.
What is the surgical option?
Typically, if you have a good response to the chemotherapy and there has not been any metastatic disease evident, then a mastectomy and usually a full lymph node dissection, although that's a part that's in constant discussion, I think, about the removal of lymph nodes. If it's already assumed to be there, is it necessary to remove all the lymph nodes.
And in lieu of surgery, is radiation ever used?
Radiation is almost always used because this is in the skin, and that's one of the few methods to maybe destroy any remaining cancer cells.
So it's mastectomy and
Right.
radiation.
The full, as people say, slash, burn, and poison. It's the
It's
whole
a
gamut.
very, very then aggressive treatment
Yes.
because unlike other breast cancers where you can somewhat spare the surface layers of the skin and hone in the radiation closer to the tumor site, in this case you purposely have to radiate the skin, so even the treatment is painful.
Correct. And there are some centers that are even doing twice-a-day radiation in an effort to try and control that recurrence, because it frequently does recur in the skin. And once you develop something called skin metastasis or cutaneous metastasis, they can be very, very difficult to control.
Is inflammatory breast cancer a disease that is at great risk for distant metastases?
Yes. And the problem with it being such a fast-growing cancer, often by the time of diagnosis, since you may be on an antibiotic a round or two, and doctors arguing about whether this could actually be inflammatory breast cancer, it's moving through the body quickly.
So it's delayed sometimes, I'm going to guess, more than sometimes in diagnosis.
It's been real important to work with the National Comprehensive Cancer Network on their breast cancer screening guidelines, as well as their treatment guidelines, to help those who don't see it on a regular basis understand what they need to do.
Yes, it would seem to me that because it presents so differently than the majority of other breast cancers, that there needs to be more patient education. So when you talk about breast self-exam and screening and what to look for, this one is easy to fall through the cracks because you may be getting mammograms, but that doesn't mean you're going to be able to get an early diagnosis.
Right. It's one of the reasons we use the tagline of "you don't have to have a lump to have breast cancer," because we've been inundated with the information about get your annual mammogram. If it comes back fine, you're good. I had a mammogram that said there was nothing there, and I had florid symptoms, but the radiologist said, I don't see anything on the mammogram, you're fine.
And you also mentioned that this is a cancer that's more prevalent in younger women.
Yes.
So would you call this one of the younger adult cancers that one could be at risk for?
Absolutely. We do try to get our message out to, particularly to young women, to pay attention to their bodies. It costs nothing to look in a mirror, to pay attention to changes. And we tell people that you need to know what normal looks like for you. Get out of the shower and stand and look in the mirror for a moment. Mm-hmm. Raise your arms, pay attention.
It's not just palpation.
No. In fact, a lot of inflammatory is looking. The skin may look dimpled. And if you see a change that does not go away on its own within a week or two, we all have changes. You have rashes, you have bug bites, you have, a number of different things can happen. But if that doesn't go away in a 2-week time period, we say it's time to see someone and get to the bottom of things. So you have to take responsibility for your health.
Ginny, I get to see you a few times a year at these different conferences, and I always find you to be energetic, passionate, articulate.
Thank you.
And a real pleasure to talk to you. You're smart and committed, and you taught us a lot today.
Thank you. I continue to learn and feel like I hoped we would be at a point by now after 13 years when there would be no need for our organization. But I'm committed to, as long as I'm on this side of the grass and continuing to do well, I'll keep at it until we don't, when I can go spend time with my grandchildren.
I hear that. Thank you, Ginny Mason, Executive Director of the Inflammatory Breast Cancer Research Foundation. Thank you, Ginny.
Oh, thank you.